So it's going to be really cool when I have a gray-headed mullet, which is, depending on how long things are shut down, you know, we'll see. I'm not going to get a perm back there, though. So we'll do this as frequently as we need to. I want to know if you guys have questions, comments, or concerns, okay? I have said from day one, and will continue to say, things are going to change. This is a static event. This is not a, sorry, this is a dynamic event. This is not a static event. And the changes will be based on what's best for the staff, what's best for the patient, and what is working or not working around the country, okay? One common question that I'm getting right now is a couple hospitals on the East Coast have come out and have everybody masking for everything, okay? At this point, I do not endorse that. We will come up with guidance for something very conservative, but if everybody masked for everything, number one, you will run out of masks. New York City is out of masks, okay? So they are now taking care of COVID patients with no PPE, okay? We're not gonna let that happen, okay? Number two, there's no evidence that universal masking does anything, and honestly, universal masking can actually spread the infection. If you have your mask on down in the cafeteria, you take it off to eat and your mask has COVID on it, while you're eating, you're leaving it on the table and the next person through is gonna get it on their hands and they become infected. So universal masking has the potential to actually cause more harm than good. We will do our best within the next day or two to have guidance documents up so that people throughout the hospital know what to do. Okay, so we're working on that. We identify that as an issue. I will tell you that unless there's literature that says otherwise, you're going to see my made-for-radio face like this on this unit every day. Unless there's something that says that we should be doing it, that's the only way I'm doing it, okay? And right now there is no evidence, and my friends out in Seattle, my friends in California, they are not universally masking. They're following the exact same processes that we are. The other thing I want to tell you is that our isolation practices line up 100% with the Society for Critical Care Medicine guidelines that came out for PPE, okay? We are in tune with them every single area. Those are guidelines from people from China, Italy, people that have been dealing with this for a few weeks longer than we have. So our current practices and whatnot are absolutely fine, okay? Last thing I'm gonna tell you though, is that there is gonna be a change slightly based on availability of PPE. We are going to be not today, but in the near future, going to non-fitted N95 masks, okay? We have about 30,000 masks that are having their straps redone, and we're on the verge of having more N95s than we are our regular mask with a face shield, okay? When that happens, we will wear N95s. I've got one in my office that is not fit tested. And we will use that just like we do a surgical mask, and you'll have to put eye protection on. If you're not fit tested, if we're doing an intubation, if we're doing an aerosolized generating procedure, you would still have to put on a PAPR, you would still have to change at that point. The advantage of the N95 is with the proper storage, you can keep it for 30 days. And you can use it for multiple patients. That's a game changer. Right now, the surgical masks you can use for the same patient for the same day and throw it away. But N95s have now been verified to be able to be used for 30 days as long as they're not grossly soiled, as long as the straps aren't breaking or whatnot. And they can be used in replacement of a surgical mask as long as you add eye protection. And then between patients and whatnot, you have a bag to put it in and you restore it. So that is why this is going to change, okay, is because those masks are going to become available very shortly, okay? So again, change is coming, and I do not want to hear anybody panic because, great, I've been in here with a surgical mask and now no. The N95 unfitted is going to give you the exact same protection. And if you're doing an intubation, you're doing a procedure that's generating aerosols, then you need to be fit tested, okay? But with those N95s, they do not have eye protection, so you will have to have something for that. You might actually see me up here. I have a pair of dolphin swim goggles. And if I have to go in a room, I might actually wear those because that's what they're doing on the West Coast for eye protection is they are wearing swim goggles, okay? And the last thing, because there's a lot of questions on this one, the last thing is negative pressure. Of everything that we do, negative pressure is the least important process that we do. It's that extra level of protection that we try to offer, okay? We really don't need it, okay? If I couldn't get a patient into a room to intubate them into a negative pressure room, put your PAPR on, put your fit tested N95 on with your eye protection, you will be fine. Because we're gonna have processes where we don't have a negative pressure room. That is, again, if we got it, great. If not, don't worry about it, okay? It'd actually be really nice if the CDC would say just stop with the negative pressure, but it still says it's optional if you can, okay? So if somebody gets tubed in 5, it's not a negative pressure. As long as you had on your N95, as long as you had your eye protection, your gown, and your gloves, fine, okay? Negative pressure is, do it if we can. Okay, I will shut up now and take any questions.
Only questions about PPE or about the virus itself?
Ask anything.
I just have a question. Have you seen with any of the positive COVIDs neurological?
Without respiratory symptoms, that would be very, very unusual. I know of one case report out of China where they did have an encephalopathy or encephalitis from coronavirus. But it should be associated, this is a respiratory virus, it should be associated with respiratory symptoms.
She is, that's why I'm asking. It's very out of character, that's why I was asking.
What about GI stuff?
GI stuff at first they said was very rare, but we are seeing some GI issues like a day or two before the respiratory symptoms start. The problem is, the last one I got caught on 2 days before, or called on, 2 days before I'd gone to Taco Bell, okay? Hopefully none of you guys have stock in Taco Bell, but don't go to Taco Bell right now, okay? That meat's probably sitting there and who knows what's in it. But,
What is it not like?
I'm an infectious disease doc. Don't ever go to Taco Bell ever, okay? Just like don't eat sushi. But there, again, there should be respiratory symptoms. But again, the problem is people always get the squirts, they always throw up, and majority of these folks are not. I will tell you that the data that's come out so far, 90% of the COVID tests are negative, okay? Only about 10% of the people that are getting tested actually have it, okay?
I have another question.
Yes.
Do we know a lot about negative, like false negatives?
So the nasopharyngeal swab looks like it's about 75% sensitive. I got a lot of pushback yesterday. I wanted to order a combi cath on our gentleman who really looks like he has it, and we ended up not doing it. So that's why our team is going to make more of a clinical, and some of these folks, a clinical decision. We're obviously admitting a lot of folks that don't have it. They have congestive heart failure. If their test is negative, I'm fine. If this walks like COVID and talks like COVID and they're intubated and they've got ARDS and we don't have any other explanation, I may end up keeping them up here and treating them as such. And again, that's why every patient encounter, we go in PPE just like it's a positive. And then again, there may be folks that come back negative that I look at and say, you know what? I'm not convinced, and we will keep them up here or we'll send them home and keep them in quarantine. So we're gonna make clinical decisions based on the testing until we get a little better test, which they're getting better already. But you will notice and you will panic, or your colleagues downstairs will panic, because the test says the test was negative. It doesn't completely rule it out. Every single test that comes out from a lab has a statement for an infectious disease type of thing, when they're first developing the test, they always put that kind of CYA comment on the test, because it is true. One of the things for you all to continue to emphasize and ask the patients is, was this the worst experience of your life when they collected the nasopharyngeal swab? Again, it should suck. Your brain should hurt, okay? If they said, no, they just swabbed the front of my nose, then that test result is useless to me. We're gonna have to do a deeper swab. So please incorporate that question into your history of, again, an NP swab should be a very memorable experience. Okay.
Now, when we get these other masks, the non-fitted N95, what kind of eye protection should we be providing our own, or will they have?
For now, great question. So should we be providing our own eye protection? For now, we have, we were ahead of the curve in preparing for this, and so we have some for lack of a better term, industrial goggles that are really nice. We will use those. Those of you at home, I have already set aside, I don't do much woodworking, but I do have a pair of goggles that are kind of big. I've set those aside. I will not be using those while we have them, but just being prepared and having that standby, I think is completely reasonable. The homemade masks that everybody is talking about is a last resort, okay? We have Premier as a website for that. I forget the URL off the top of my head. But for now, we will use our equipment. We will use our N95s. They have changed the federal rules in terms of industrial N95s are now allowed to be made in the hospital. So the N95 supply, honestly, should be just robust here if we can get through this initial bolus. And with our 30,000, we should be just fine from that standpoint. But just having some eye protection at home that you have set aside for just in case, I think is reasonable. Again, glasses are better than nothing, but I would prefer not, we're really not going to rely on regular glasses in general.
Goggles in the husband's, my husband.
Again, so something that just gives you, again, just to try to protect from splash. There was another question. Yeah.
There's a lot of concern about co-infections, and we, would roll out flu and all the other stuff, and then if they were positive, then we would transfer them out, and there was a lot of concern, a lot of articles, a lot of stuff about they could actually have those.
So correct, our policy, again, in the ever-changing face of this, the first set of literature said less than 2% co-infection. That was out of China. Once we got into Italy last week, the study out of California showed 22% co-infection, mostly with RSV, respiratory syncytial virus, a little bit with parainfluenza. That study did not show any co-infection with influenza, but my friends in Chicago and down in Miami have seen it. So last Wednesday, when that report came out and that literature was made available, we immediately stopped using a positive viral test as a reason for ruling, saying, oh, this is not it, and we are now keeping people up here with influenza A for the very, very small chance of a co-infection. To date, bacterial infection is really not being reported early on. So we admit somebody up here and they come back with strep pneumo in their blood, or they have Staph aureus in their blood, and nothing else to suggest COVID, then we're going to probably, in most situations, take them out and manage them, accordingly. But the viral co-infection in our hospital, in our system, this is not true everywhere. Some systems in the general area are still saying a positive flu, you're out of rule out. Not anymore. Okay? You have a positive flu, you're staying up here until we get your COVID test back. My biggest frustration has been the testing, and we got people just lingering, waiting for tests, some people up to 8 days. Quest did change their platform yesterday, and they are now saying 1 to 2 days for results to come back. We should, knock on wood, maybe, not going to put my job on the line for this, we could have CompuNet-based testing with 2 of our platforms as early as next week, at which point we could maybe, possibly, hopefully, have testing same day, maybe less. I won't go any shorter than that. That is a game changer, okay? There may be a change in test protocol at that point. If we can run the test and we can get the test results back, I may go to testing people twice, okay? There's no reason to do that right now because they're already waiting a week. Why should we wait 2 weeks? It doesn't help to do it 2 weeks. We're gonna have to make clinical decisions. But testing will make everybody's life easier when we have access to it. And we're closer today than we were last week. But with everything in this outbreak, in this pandemic, I want it here, I want to see it, I want to know that we have it, and then I'll take a step back, take a deep breath, and know that things are different. The other thing I'm going to go do a video on here in a little bit, okay, and you guys don't panic when I say this. It is not if you get exposed, it's when you get exposed. Your exposure could be your kid. Your exposure could be your grandkid. Your exposure could be your husband. Your exposure could be your wife. Your exposure could be the grocery cart. We will be exposed. Sorry, we're humans. So it's not if you get exposed, it's when. And the employee health guidelines for what we're going to do for those situations are almost finalized. And they probably are finalized by now. And I'll be doing a video kind of announcing those. We are not quarantine workers, okay? That's while the CDC document is out there, no hospital that knows what they're doing is following those CDC guidelines for mandatory quarantine. We're basing it on symptoms. If you are sick, you don't work, okay? But we are not quarantining. If we have a misstep where somebody was exposed to a confirmed case, and I shouldn't say that, when we have a misstep, okay? This virus, going back to your diarrhea and GI questions, is so crazy that we are going to have folks that we do not identify. As aggressively as we're trying to be, we will have folks we don't identify. It's just that plain and simple. If somebody comes back positive, you will keep working, you will wear a mask to make sure you don't spread it to anybody else, and then you will monitor for any signs or symptoms of infection. Okay? Other, I've seen 2 case reports of reinfection, but I'm not convinced that those just weren't prolonged shedding, okay? It probably is in stool for 21 or so days, okay? Bleep this part out, but so far nobody has done the semen study, so we don't know how long it's in sperm, and I'm glad we don't know that data, okay? We have it for Ebola. Okay, and that was too much information for me. I don't want study of that for coronavirus. But reinfection appears to be very low, and that's based on once the areas get through their outbreak, their rates start going down. If reinfection was happening, the rates would start going up. And so far, again, China, South Korea, and whatnot, once they get ahead of it and their rates go down, they're staying down. What I can't tell you yet, because we don't know, is will it be like influenza, which every year we see a little tweak and we get a little different version of it. Is it going to be that or not? We don't know yet, okay? I don't think so, because the other coronaviruses, we've all had coronavirus. Other coronaviruses don't necessarily do that, but we will. We'll see. But right now, once somebody has positive, and then we don't know, eventually we'll be tested to see if we have positive antibodies, and we'll know how many of us had this, and there's probably some of us that had it and had 0 symptoms. Okay? So that's what I expect. Okay, it's been 20 minutes. Any other questions?
Dr. Burdette,
Yes.
I hear a lot of talk about how long it stays aerosolized. And
So,
I
good
heard
question.
a lot from that.
So the aerosolization study that came out was literally done in a metal tin where they aerosolized it intentionally to see how long the virus would live up in the air. They kept it up in the air to study it, to do the viral loads and all that kind of stuff. It was not a true infectious study of a patient to see how long it stays up. World Health Organization repeatedly has come back and said this is a droplet. It's a little further droplet than other droplets. Influenza only goes about 3 feet. This goes about 6 feet. But once it goes out, it goes down. The idea behind the negative pressure for the aerosolized generating procedures is that's not a regular cough and all that kind of stuff. And the other thing about the aerosolized generating procedures, if you're down at the foot of the bed, we're gonna have you in a PAP, we're gonna have you in a N95, but that's probably not as important versus if you are up intubating, if you're up hooking the person up, you're right up in their face and those droplets haven't had a chance to settle. So it is not aerosolized, it's not like tuberculosis, it's not like chickenpox, which stays up for a long, long time. This goes out and goes down. We could have, if we were almost, there are some places who have done away with the airborne altogether and are just doing the droplet, even for the procedures. As long as we can fit test and as long as we can get the N95s and we can do it as an airborne for the aerosolized generating procedures, the AGPs, we are going to continue to do that.
Should we be covering our hair? I know I go right home and shower and stuff, but no.
No. And again, if you're wearing the PPE, your clothes are not, you know, if they spit a loogie on your shoe, then we need to take a wipe and wipe your shoe off, you know, stuff like that. But other than that, your PPE is fine.
I've had other staff questions, and I also had another doctor tell my staff that people who are working up here should not be coming down to our break room. Can you just? This is the most. When we walk up and down, people are wearing their PPE. I feel safer here than some.
Absolutely. I don't know if necessarily want this on video, but this is the most controlled scenario in the hospital because everybody here is going in every encounter outside of a true like life or death emergency, which is again, we're so much hawks on stuff that should be very rare. We're safer up here than we are downstairs. Because again, with this virus, you just look at other hospitals in the area and around the country, people get it, and then a week, 10 days into admission, you realize that they had it. So I'm not, you know, the other hospital is having people change gown, you put in hospital scrubs when you get in. That is, I'm mirroring our process over based on Seattle. My friend John Lynch has run their program. He is guiding hundreds of hospitals now through some stuff. And all of our documents, if you just want to do a Google search for University of Washington coronavirus response, they have everything on there. They have shared everything. And they're now working with the CDC to try to get some stuff updated. That is what we're mirroring our policies and practices based on. Where I would be more concerned about that scenario is that person who's been wearing their mask everywhere and they go down to the lounge to eat and they set their mask or wearing around their elbow. That's a huge issue potentially. So, no, you all are fine.
What is the lead for the septic process?
So the patients with ARDS are sometimes sick for 3 weeks. Everybody else, you know, the 3 people that I heard from this week that tested positive, on day 2 after their positive test, they were already back outside running their 5K. I mean, that's, most folks, again, what I think we're gonna find out is many of us probably got it, didn't even know. Okay, I've even seen data now that says 98% of people have minimal to no symptoms. The original data said 80% no symptoms, 15% mild to moderate, 5% severe. I think what we're gonna find out is way more folks had it. And then once we realize we've had it and we've got people that are exposed, now these things start dropping because we don't have people at risk. You don't have a way to spread it nearly as, nearly as much. But most folks, a few days of symptoms, but on the far extreme with the bad ARDS, it could last up to 3 weeks. And anywhere in between. Okay. If you have issues, if you have disagreements, you go to your leadership, they will take it to me, okay? I want to take everything face on, and when things change, I'm going to tell you they're changing. And I'm telling you right now, things will change, and when they change, I will tell you why, okay? But I want you guys up here, you know, at the front lines to know why we're doing and what we're doing and why we're making the change that we make. And it will all be based on what's best for our patients and what's best for you. Any other questions? Okay, and we'll do this again when we need to. Okay, thank you.
Thank you.